Good morning. You are all very welcome to this seminar arranged by Smer, the Swedish Council on Medical Ethics. I'm Kjell Asplund. I'm chairing Smer. Last year, Smer turned 30, and to celebrate this event, we initiated a prize for a person that has made special contributions to Swedish medical ethics. We had a prize committee. The choice for the first recipient of the prize was quite easy one. Göran Hermeréns, the first professor of medical ethics in the country, a key person in developing medical ethics, both as an academic discipline and in its practical implication when it comes to policy making, decision making. Göran has also been a key figure at the European level, chairing the European Group of Ethics for a number of years. The formal justification for this prize to Göran read, "For his particularly valuable actions for medical ethics, nationally as well as internationally." Smer cannot offer a big prize check or a big glass bowl or so, but we offered a diploma and the possibility to arrange a seminar on a topic of the prize winner's choice. And Göran has then selected this topic: how much and why are we prepared to pay to prolong or improve somebody's life? Hard choices, qualis, and ethics. Göran has assembled, perhaps I should say that Göran was really a key person in developing the ethical platform for priority setting in Swedish healthcare. So today's topic is very much related to one of the principles. We have the principle of human dignity, the principle of needs and solidarity, but also the cost-effectiveness principle. So this is clearly related to this. Göran has assembled a very distinguished panel of national and international experts. This morning session will be held in English, and then for the afternoon, we'll go over to Swedish. Göran will chair this day. I had some practical information as well. Well, this event will be broadcasted on YouTube. There will be a YouTube recording. So if anyone feels uncomfortable with that, please sit in the back and you will not appear on the TV, if that is a problem. It's important also when you put questions, to speak into the microphones so the YouTube audience can hear what you are commenting or asking. And at our website, you will also find other recordings from other events that we have had. Then as for lunch, are there any practical instructions? This will be in the restaurant nearby. And we pay for it. Good. And are we served by the table, or do we have a tray lunch? It's a tray lunch, so you just join the line then. So with that, I wish you all very, very welcome, and hand over to Göran.
Splendid. Thank you very much, Kjell, for the kind words. I will, during the next 20 minutes, pave the way for a discussion of the question, how much are we prepared to pay to save a life or improve somebody's quality of life? If you have good eyes, you can see a number of ants in this picture, and they are carrying a stick. And of course, the success of their endeavor will depend on in what direction they are going and if they all are going in the same direction. And the picture lends itself to a symbolic interpretation. The stick is the healthcare system and we are the ants. And the success of our endeavor will depend on in what direction we are going and if we are all going in the same direction. The main message is that the answer to the question in the title of this talk will not only depend on the economic resources of our society or its level of technical development, but also on underlying ethical points of departure, in particular our ideas about the goals and mission of healthcare and on what methods are used to estimate the effects of healthcare interventions, and that's where QALYs enter into the picture. How much should be spent on what? As you can see from this cutting from Läkartidningen, some health economists seem to think that they have the key to the solution of this problem. And that's why I will focus in particular on the conflicts that may exist between the moral underpinning of the goals of healthcare and the assumptions and methods of health economy, and especially the use of quality-adjusted life years. So this is the menu. Why is this become a hot issue? For a number of reasons. First, there is a changing health panorama in the European Union. More people become elderly, and those over 75 often have many different diagnoses. And so the cost of healthcare is increasing all the time. Secondly, new expensive drugs are driving up the cost of healthcare. There's a deregulation trend in the US, Japan, and EU, which introduce changes in the rules. And two recent commissions in Norway suggest ways to deal with some of these issues, and I will comment on these different points during the talk. Here is an example of an expensive drug. Drug company Pharma Ltd has a drug that, given in a certain dose, is tested and approved for a treatment of a disease, say leukemia. It's been successfully used for many years off-label for another disease, multiple sclerosis. Now Pharma Ltd withdraws this drug and applies for approval to prescribe the drug for another disease, for multiple sclerosis. And when used for this disease, half the dose is required compared to when it's used for the first disease, leukemia. And the company indicates that the price for the drug now will be increased up to 20 times. This, ladies and gentlemen, is not science fiction. It's based on a real case, as you can see from this cutting. And two commissions in Norway, inspired by utilitarian considerations and the fair innings argument, taking 70 as the statistical life years to be expected as a point of departure for their recommendations. And the first commission, the Norheim Commission, was sharply criticized on several grounds, not least concerning the criterion of lost health. It was considered to be too theoretical, too bureaucratic, and too difficult to use in practice. A new commission was appointed later, headed by a health economist, and the recommendations of which were also criticized. And incidentally, the recommendations of both commissions differ very much from the ethical framework from priority setting used in Sweden. Now, let's move on to QALYs and the goals of healthcare to see if there are any problems. Now, to see if and in what way some assumptions, concepts, and methods of health economy will come into conflict with the goals of healthcare, these goals must, of course, be clearly stated. So which are they? That's a question that is not so easy to answer. First of all, a distinction must be made between the general goals of practicing medical doctors and healthcare personnel. that is concerned with the health-related needs of individual patients. So the health of my patient is the supreme law. That's what the Latin means underneath. And that is something different from the general goals of those responsible setting up or administering the healthcare system that is concerned with societal aspects, including the responsibilities of the state and the county councils. And if we look at the general goals of practicing medical doctors and healthcare personnel, it's quite complex, and they pull in different directions, as the discussion in intensive care illustrates. First, to preserve, restore, and improve health, to combat disease and suffering, alleviate suffering, to prevent ill health, and or to preserve, restore, and improve quality of life, including to fight and prevent poor quality of life. So this is a very complex set of different goals pulling in different directions. If we look at the general goals of healthcare systems, we come up with something different. Equal opportunities, to reduce the differences between the chances of people to obtain good health, which is something different from equal outcome, where the goal is to reduce inequalities in health between different socio-economic groups in society. I will underline again and again what you see in red at the bottom here, that the goals are not equivalent. So either we must make a choice or we must rank them in importance. The fourth goal would be improved health of the population as a whole. That is, to as much as possible improve the health of the whole population. Finally, health equity or fair distribution. That is, to distribute the available scarce resources of healthcare in as fairly as possible. Now, prevention creates problems, and prevention is difficult. It's difficult because it belongs under several headings here, depending on whether the focus is on the health of an individual patient or on saving statistical lives. Of course, it's the goal of doctors to provide their patients with adequate preventive measures, advise particular patients on what to avoid and what to do, on the need for a certain diet, a certain amount of exercise, and things like that. But it is the responsibility of the healthcare administrators and the state. Kjell personifies the state in this morning's newspaper, to organize a proper system of prevention, including appropriate vaccination programs, and to see to it that adequate and necessary legislation is in place. Now, values in the ranking of interventions can be either explicit or implicit. In the first case, facts about the cost of interventions, including drugs, their effects, as well as the needs of the population as a whole, can be combined with explicit goals of healthcare, goals like the ones just mentioned from 1 to 5. And again, we may have to make a choice between them or rank them in importance. First this, then that, and that only if it doesn't clash with the first. But it can also be done implicitly. And in that case, the definitions or methods used are based on certain normative assumptions, for example, influenced by utilitarianism, which may not be stated explicitly, or such assumptions are introduced by reinterpreting the goals of healthcare and medicine. And it's the latter I will focus on here, and I'll provide some examples for discussion. So the first concerns age discrimination. And we all know that persons over 75 years of age have statistically fewer remaining good life years than those who are 25. And the use of QALYs to estimate the effects of medical interventions can open up for discrimination of the elderly. And both if age is used as the only criterion or combined with others when priorities are decided. Now, the statistical life years to be expected are of little use when it comes to decide about the treatment of an individual, because, as I said earlier in the discussion of the goals of healthcare personnel, the first responsibility of the doctor and all other personnel, including nurses and technicians, is the health of the patient. And the doctor has to decide what's good for the patient, what should be done for a particular old or otherwise weak person, and of course also what should not be done, what should be avoided. And I have two examples to illustrate the problem. The first is this. Suppose we compare two new drugs or cell therapies for two groups of patients, roughly 30 and 70 years respectively. They suffer from different diseases, but their chronic pains are equally severe. The interventions alleviate symptoms for both equally much. Should we then, as has been proposed, accept 2 or 3 times higher cost per patient and year for the intervention in the first group compared to the last? The second example is this. Suppose we compare two new surgical procedures with the same and equally long-lasting effect for each of the two groups statistically. Then the group of those who are 30 years old should be prioritized for 2 reasons. The first is this. Suppose those in the group of 30 years will have to live with their problems for 50 years, statistically, because 80 years is then taken as the reference point, if they do not get the new treatment, whereas those who are 70 will have to live with their problems for another 10, 15 years. And the proposed conclusion is that we should accept 5 to 8 times as high cost for this surgical intervention for those who are 30 years old. Now, a problem that arises in this context is that in the operationalization that is proposed to be used in deciding about the levels of cost here, the typical age of the target group is quite central, and nevertheless it's argued that in clinical praxis, the age of the patient should not be included in the decisions about the severity of the disease. So if this is consistent, is something that we can discuss. Now, severity is an important concept in priority setting, and suppose the severity of a condition is defined in terms of the sum of the number of life years that the patient typically will lose and the loss of quality of life during the years the patient is living with the disease. Now, if severity is defined in that way, the consequence is that those who get asthma or cancer when they are 40 should be considered to be more seriously ill than those who are hit by the same disease when they are 60, and hence the patient who is 40 should be prioritized. And should the remaining time of living not be taken into account? That does not follow, and there are other ways than using QALYs to consider this, and I suppose we will hear something by Dr. Beresniak about this later today. And of course, a challenge, of course, is that there are individual variations of preferences, and there is the problem of interpersonal comparisons. Let's move to deregulation dilemmas that I mentioned in the introduction. In Japan and the US, there are now strong movements in favor of deregulating safety and efficacy testing and letting the market decide. I have some references to a few papers describing this. And drugs are put on the market with what's called conditional approval, which means that the patients will be exposed to the risks. And there are different interests at stake here, as you realize. Business interests, patients' interest in getting early access to potentially beneficial drugs, promotion of safety and efficacy, and these interests pull in different directions, and they can be balanced against each other in more ways than one. Obviously, both regulation and deregulation can be graded. A system can be more or less deregulated, more or less regulated, so there are differences in degrees, and in each case, the underlying values must be made explicit if we want a constructive discussion about the issues. Now, if we look at history, we can see a direct link from the 18th century to today. The famous invisible hand of Adam Smith is the general idea behind the deregulation efforts. And the idea is that individuals' efforts to pursue their own interest may frequently benefit society more than if their actions were planned and directly intended to benefit society. And these are his main writings. Now, costs of regulation and deregulation, which are they, and how can they be estimated, and are the methods using QALYs a solution? Peltzman wrote in 1973 that the 1962 drug amendments in the US sought to reduce consumer waste on ineffective drugs. He continues, this goal appears to have been obtained, but the costs in the process seem clearly to have outweighed the benefits. And he adds that the amendments have produced a substantial decline in drug innovation since 1962. And 4 questions that we might like to consider. Are these consequences due to the choice of the particular regulation or deregulation option and only to this choice? Are the consequences of the options the only relevant aspects to consider in the moral evaluation of these options? Does it matter if the consequences were foreseen, intended, could have been prevented, were caused by negligence or bad luck, were part of a larger plan, ethnic cleansing, for example. As you know, in Germany in the 30s, Volksgesundheit was a big idea, and in the name of Volksgesundheit, ethnic cleansing were taking place. And 4th, does it matter if the ways of preventing the consequences of these options are very different, much more difficult and cumbersome in one case rather than in another? Now, which values are at stake here? Of course, too much regulation can have damaging effects and may block innovation. We may wonder if the markets will disappear due to over-regulation. But efficiency is not the only value at stake here. What about solidarity? What about the basic goals of medicine to help those who need help, regardless of whether they are willing or able to pay? Justice and fairness are also important values, not least in the choices between different ways of spending healthcare resources. And in some countries, and Sweden is an example, as you know, decisions are taken by national committees that a particular drug is too expensive considering its effectiveness. And 1 million per QALY is one of the limits here. And such decisions concern groups, that is, patients with a particular disease. But decisions concerning individual patients are made by doctors. And this may lead to different decisions in different hospitals and in different parts of the country, which may be regarded as unfair. So the decision concerning life and death may depend on where you happen to live, and which is a problem here. Now, a key question here, in addition to the 4 I mentioned earlier, is this one. Can we put a non-arbitrary price on human life and on a certain reduction of a person's quality of life, so that we can then compare and evaluate the options of regulating or deregulating in quantitative terms? And of course, the introduction of QALYs may be an attempt to do this, but are methods using QALYs a solution? Some may be tempted to answer yes, others may be tempted to answer no, and why? We should note, and that's been my main message here, the value context in which these calculations take place. Now, can we put a price on everything? Kant, Immanuel, famously made a distinction between things that can be bought and sold, such as vegetables, clothes, pencils, where the price is regulated by the market mechanisms like supply and demand, and what we cannot put a price on, such as human lives and human dignity. And of course, that has implications for the discussion on priority setting. I will finish with a few comments on priority setting or thoughts about priority setting in healthcare. Those who are interested in the empirical questions, how decisions about priorities actually are made in healthcare, they have to take an interest also in factors such as historical accidents, media coverage, charismatic personalities with strong will, waste of resources, non-compliance by patients, lack of continuity in healthcare, and shortage of staff. All these things accidentally have an influence on what is being done in healthcare. But those who are interested in the normative questions about how priorities ought to be done and on what grounds decisions should be made will have to make an analysis of the goals of healthcare and the moral and ethical underpinnings of these goals, a central concern. And a key question is the one in blue here, how to increase the efficiency of the system without conflicts with the goals of healthcare. And I think we should take the admonition from the rainforest of Costa Rica seriously, to slow down and consider the value implications and the value context. And because these value conflicts need examination. And I've talked about the tensions between the goals of healthcare and methods used in QALYs. We will hear more about that today. But also conflicts between quality management, freedom of the doctor, and the economic interests of hospitals and county councils. So my main message has been to stress the role and importance of value premises, the normative context and assumptions in which the quality calculations take place, in order to identify conflicts of interest and conflicts of values, which cannot be solved by economy. Because in the end, we have to make up our minds as to what kind of society we want to hand over to our children and grandchildren, and their children and grandchildren for many generations to come. That's what we need to think about. Thank you very much for your attention. Thank you.